Welcome back, ladies and gentlemen. We will now move on to the 10th symposium, which is on a series of miscellaneous topics. The chairpersons for this session will be Consultant Respiratory Physician Dr. Asha Samaranayaka and Consultant Respiratory Physician Dr. Suranga Manilgama.
Thank you very much for that kind introduction. Good morning, everyone. So we are moving to witness 10th Symposium of RESPA 2024, that is on short miscellaneous lectures. We will discuss about 4 topics in 20 minutes slots. So I would like to introduce our first speaker, Dr. Suresh Lakmuthu. Dr. Suresh is a consultant respiratory physician currently working in General Hospital Badulla. He's a product of 23rd batch of Ruhuna Medical Faculty, where I study as well. And he's basically from down south. I'm so privileged to introduce him today to speak about eosinophilic lung diseases. Over to you, Dr. Suresh.
Thank you very much for the kind introduction. The topic today for me is eosinophilic lung disease. I know this is not a palatable topic, but I try to add some taste to it. Now, so this is the outline of my talk. So pathology, eosinophilic airway diseases, and eosinophilic pneumonias. So before talking about few words about eosinophils, eosinophils are, participating in a broad range of both pathological and a normal process. So primary key effector cells against parasitic infections is eosinophils. So in addition to that, so eosinophils are implicated in number of allergic and immune disorders. So in addition to that, his physiological role involved it regulate metabolism in the normal tissue. Now, what are the defining criteria for eosinophilic lung disease? The first is blood eosinophil counts more than 500, often in tandem with pulmonary opacities. Not every and each patients reach this criteria. Therefore, there are some additional criteria. So they are the bowel fluids more than 10% of the eosinophil differentials, or sputum eosinophilia. So if you can detect eosinophilic inflammation in the tissue, so we can take it as a eosinophilic lung disease as well. Now, talking about the pathology of eosinophilic lung disease, there are 2 types of eosinophils. So there are circulating eosinophils and a tissue-dwelling eosinophils. Now, recent studies have found that there are 2 main types of tissue-dwelling eosinophils. There are steady-state eosinophils and inflammatory eosinophils. Under normal conditions, steady-state eosinophils regulate the normal homeostasis in the tissue. But under the pathological conditions, these inflammatory cells, E1, E2 cells come into play. Now, so still we don't know these pathological subsets exist or just a continuum of state of activation. Now, I can broadly categorize eosinophilic lung disease into 2. There are eosinophilic airway disease, mainly bronchocentric inflammation, and eosinophilic pneumonias. Now, so most of the studies have been done on eosinophilic airway disease rather than eosinophilic pneumonias. So these slides nicely depict underlying inflammatory pathways involving the eosinophilic inflammation. Now, so eosinophilic inflammation is not just a word, it's a combination of multiple inflammatory pathways. Now, what happened? When the fungal spores being inhaled, it activates epithelial cells here, and it also activates T helper cells to antigen-presenting pathways. Basically, innate lymphoid cells and T helper cells are being activated by the fungal spores or fungal elements. Now, so we can see three inflammatory pathways here. First one is IL-13 here. Second one is IL-4 here. And the third one is IL-5. Now, the IL-5, it consists of a distinct pathway. What happens is IL-5 is secreted by the ILC2 cell or T helper T cell. So they stimulate bone marrow to produce pathological eosinophils. Right? In addition to that, they also contribute to the luminal eosinophilia as well. So it basically IL-5 stimulate bone marrow to produce eosinophils, and it activate, and it also trigger the dying pathway of the eosinophils. Now, that is IL-5. IL-13 here, the IL-13 is involving tissue remodeling and the fibrotic process, right? So IL-13 mainly stimulate epithelial cells to produce nitric oxide. So it also stimulates fibroblasts to produce E-toxins. So these E-toxins go and in turn help eosinophil to these E-toxins go and help eosinophil to transmigrate the endothelium. So basically IL-13 involving in the tissue eosinophilia, right? So IL-5, IL-4. So IL-4 is involving, it stimulates B cell to produce immunoglobulins, basically. So IL-4, there are certain instances where you won't get IL-4, right? So in that instances, you don't see any immunoglobulin response. Now, depending on the stimulate, depending on the host response, so one pathway may dominate in the other, right? So then the heterogeneity of the disease. Now, what are the markers of eosinophilic inflammations? Now, they are sputum eosinophils, peripheral eosinophils, that's called absolute eosinophil count, pheno, and eosinophilic degradation products. Now, sputum eosinophils, normal count is less than 1%. Sputum eosinophils considered as the gold standard for the eosinophilic inflammation. Now, the problem associated with checking sputum eosinophils is it needs immediate processing and experienced staff, and it is relatively time-consuming as well. Now, absolute eosinophil count, this is easy to measure. It's just taking blood and checking the eosinophil count. Now, the problem associated with checking eosinophils, peripheral eosinophil count is, so even in the high probability setting, the patient with symptoms and chest radiographic changes, the sensitivity and specificity is modest. So that is the big issue measuring peripheral eosinophil counts. Now again, pheno. Pheno also has the modest sensitivity. So it is an indirect measure of eosinophilic inflammation. Now, what are the other potential biomarkers which can be measured but is still not in clinical practice? Now, this slide nicely shows the dying process of the eosinophils as induced by IL-5 cytokines. So what happened during the dying process, chromatin degranulates and chromatin condense, and it secretes into the intercellular space or to the luminal space. It produces CLC particles. What do you call that? You call it charcoal-laden crystals. It made of chromatin particles in the eosinophils. In addition to that, there are highly cationic molecules stored in the cytoplasm of the eosinophils. They also get released into the intercellular space under the influence of IL-5. Now, so we can measure these highly cationic molecules as a biomarker of eosinophilic inflammation. Now, the problem associated with measuring these biomarkers are they have very low sensitivity and a low specificity. Now, these highly cationic molecules, they are positively charged. Once they get released into the intercellular space, it get bound to the negatively charged intercellular molecules. So it's hardly come into the circulation. Other thing is that most of these biomarkers, except EPX, are very non-specific, can be found in other cells as well, like basophils, neutrophils, and the liver cells. Now, these are the potential biomarkers that can be measured in urine, sputum, and in the blood, but is still not in the clinical practice. Now, eosinophilic airway disease. Now, there are numbers of eosinophilic airway disease, T2 high asthma, aspirin exacerbated respiratory disease, ABPA, ABPM, eosinophilic bronchitis, and hypereosinophilic obliterative bronchiolitis. Now, asthma, 50% of the asthmatics are T2 high. Now, how do we diagnose? Generally, they have sputum eosinophil count is more than 3%, peripheral eosinophil count is more than 150. Generally, they have high IgE. As I said earlier, depending on the pathway, some pathways are dominating. Even some people with T2 high asthma, they don't produce high IgE levels. So that's depend on the host defense, the host mechanisms, and the antigenicity of the fungal response or whatever the environmental triggers. So in eosinophilic asthma, the eosinophils counts are relatively modest. You won't see very high eosinophils in eosinophilic asthma unless you get stimulated by some other factors like fungal infection. Now, the imaging, PO and simple asthma imaging is usually normal. You might see air trapping and airway thickening and luminal narrowing. Now, the second one is aspirin exacerbated respiratory disease. Now, this is a combination of chronic rhinosinusitis with nasal polyposis and asthma. Now, problem is 50 to 70% of the patients with severe chronic rhinosinusitis with nasal polyposis who have type 2 high asthma. So it is very difficult to differentiate these two entities. Now, generally, so this disease have the eosinophil count is more than 300, and they are very severe phenotypically, very severe phenotype of asthmatic patients with recurrent exacerbations and difficult to control with conventional measures. Now, ABPA, allergic pulmonary aspergillosis, now is a complex sensitivity reactions to fungal Aspergillus fumigatus, initially described in asthmatic patients, but now we know it's very common among COPD and post-TB patients. Now, the characteristic feature of ABPA is they produce brown color mucus plug. It's very characteristic. Now, they show the spirometry, show a obstructive spirometry. Now, if someone come with asthma, come with a recurrent exacerbation, with a mucus plug expectoration, you need to suspect whether this patient got a ABPA or not. Now, there have been multiple diagnostic criteria proposed. In 1977, the Rosenberg and Patterson, who described some criteria. In 2013, so we still now use it, the International Society for Human and Animal Mycology criteria. So it has three components. First one is predisposing conditions, the bronchial asthma and cystic fibrosis. The second ones are obligatory criteria. So sensitizations to Aspergillus fumigatus, to not for other fungus, Aspergillus fumigatus. Now, elevated level of total Ig. They use the cutoff of 1,000. Now, there are other criteria. The precipitating IgG antibodies, again, Aspergillus fumigatus. Radiographic pulmonary opacity is consistent with ABPA and a eosinophil count more than 500. Now, problem with this criteria is very low sensitivity. Now, why? Because it chooses very higher value of IgE. And there's a non-aspergillus ABPM exists. Other than aspergillus fumigatus, there are other fungi which can cause similar kind of disease. So this criteria has not considered those entities. Now then comes this Asano criteria. It has 10 components. Now, so it included history of asthma, peripheral blood eosinophilia more than 500, and they have lowered down the cutoff of IgE to 470. So it has increased the sensitivity. And immediate cutaneous hypersensitivity reaction of IgE to filamentous fungi, not only for aspergillus. So it covers the non-aspergillus ABPM as well. Now the presence of precipitations in specific IgG for filamentous fungi, not only mentioning the aspergillus. Now these are the other criteria. Now 6 out of 10 should be there to arrive the diagnosis. Now what is important, what is stress in these criteria are, they are stressing more on fungal isolations in the airways and the mucus plug. They put more stress on isolation of fungal in the airways and the mucus plugging. Now this slide nicely demonstrates how mucus plugs appear in a bronchoscopy, and this is proximal bronchiectasis. So this is mucus plugging. This is mucus plugging. So this you can see high intensity mucus here is denser than paraspinal muscles. You say high intensity mucus. Now, so Asano criteria only describe proximal bronchiectasis. There are some additional features you might see in the chest X-ray. The proximal transient migratory opacities, mass-like, sausage-shaped-like branching opacities, finger in glove-like opacities. There are many more if you come across a patient with the ABPA. In a CT, maybe centrilobular nodules, bronchiectasis, bronchoceles, high attenuation mucus, VOY toothpaste-like opacities, and a bronchial wall thickening. So in addition to proximal bronchiectasis, you might see these changes in the CT. Now, so this is a fungal spectrum of eosinophilic airway disease. So we have talked about ABPA and ABPM. So it's a combination of colonization, sensitization, and a radiological abnormalities. If it's caused by aspergillus, you say ABPA. If it's caused by non-aspergillus, you can say non-aspergillus ABPM, allergic bronchopulmonary mycosis. Now you can see some of these patient does not mount IgE response. Like in Asano criteria, they have included all of these categories. Now, there's a cohort of patients who have colonizations, sensitization, and radiological abnormalities, but does not fit into criteria either for ABP or ABPM. You say it's a AFAD, allergic fungal airway disease. Now, there are patients who have no radiological abnormalities, but they have sensitizations to fungal, filamentous fungal, but they have no colonization. You tell it severe asthma with fungal sensitization. So this comes because there are certain fungi, their spores are big, right? Some fungi are thermotolerant. So these fungi are non-thermotolerant, so they can't get and colonize inside the airway, right? Particularly during the harvesting seasons, the people use a lot of machines. So these fungal spores get into fragments, so fragmentize, and then these small fragments can get into the airways. It can sensitize the airways, cause severe asthma with fungal sensitization. And there's another entity called fungal bronchitis. You won't see any radiological abnormalities, but you see a colonization, but no sensitization. What you call is a fungal bronchitis. So it's a huge spectrum of disorder if you talk about the fungal lung disease. So fungal lung disease is essentially eosinophil lung disease. eosinophil airway disease. Now, let me talk a few words about the other airway disease, like eosinophilic bronchitis. So eosinophilic bronchitis, they come with a chronic productive cough, but they don't see any spirometric abnormalities. They are really respond to inhaled corticosteroids and the bronchodilators. Hypereosinophilic obliterative bronchiolitis is a rare entity where you see very high eosinophil counts. Histological or radiological evidence of bronchiolitis is there. But still we don't know this is a distinct disease or a kind of an entity of the other disease like asthma or hypereosinophilic syndromes. So we don't know still. Now it's generally respond to oral corticosteroids. You need to give oral corticosteroids. So it's not responding to inhaled corticosteroids or bronchodilators. Now, the second part, eosinophilic pneumonias. Now, there are primary eosinophilic pneumonias and the secondary ones. The primary, we don't know the cause. Some of these primary eosinophilic pneumonias, lung dominant, exclusively lung disease. Some of the disease, they have systemic manifestations, other evidence of other organ involvement. The secondary causes, there are many more. Now, this is a chest X-ray of a patient with acute eosinophilic pneumonia. This just looks like a bilateral multilobar consolidation and like a heart failure. Now, the important thing, this patient with acute eosinophilic pneumonia, we don't see eosinophilic response at least for the couple of days. So you will see neutrophil leukocytosis instead of eosinophil in the peripheral blood. So basically, this patient get multiple antibiotics. So at end of the day, patient will not improve. So he or she might need inhale or oral corticosteroids. Now, the lung pathology behind acute eosinophilic pneumonia is that. So this is a chest X-ray of a patient with a chronic eosinophilic pneumonia. This shows distribution of reverse Batten sign. So this is only seen in 1/3 of the patients. So the important thing is the 50% of these patients have history of asthma, and they have very high eosinophil counts, more than 100, and high EG levels, and BAL eosinophilia is very high, 40%. 80% of the patients have 40% of the BAL differentials. Now let me talk about few words about multi-organ involvement. EGPA, this X-ray show left upper lobe and middle lobe consolidation. It's very non-specific. Sometimes EGPA, eosinophilia with granulomatosis with polyangiitis, can present as acute pulmonary hemorrhage. So it is essentially an ANCA-associated vasculitis, more common in asthma population. And traditionally, we describe 3 phases in EGPA. Atopic phase, where the nasal symptoms are predominant. Second, eosinophilic phase, you get asthma symptoms. Third, vasculitic phase, you get vasculitic rash or arthritis. Now, most of the patients not develop vasculitis. Now, the disease not occur in the need sequences as well. Some people will develop asthma first, later nasal symptoms. So some people in the other way around. So, so this is a X-ray of CT films of patient with a hypereosinophilic syndrome. On the left side, you can see peripheral consolidation and a ground glass opacities. On the right side, you see a unilateral disease, mainly unilateral disease. These are some nodules found in hypereosinophilic syndrome. So generally, it's a combination of peripheral blood eosinophilia, tissue eosinophilia, and end organ dysfunction. They have very high eosinophil counts. So even though we consider hypereosinophilic syndrome as idiopathic, there are some association with the myeloproliferative and lymphoproliferative disorders. Now, secondary causes. There are several parasites which cause distinct eosinophilic syndromes. Loeffler's syndrome is one of those, is commonly caused by roundworm infections. It also can cause by hookworm as well. So TPE, tropical pulmonary erysipedia, is a disease caused by Brugia malayi lymphatic filariasis. So this is a chest CT scan of a patient with a TPE. You can see multiple random nodules. So echinococcus, so it gives rise to cystic lung disease. Cysticercosis, it gives rise to multiple nodular opacities. Toxocariasis, dog and cat rounder, which also give rise to a very non-specific findings in the CT and chest X-ray. It may be ground glass or a consolidation of opacities. Paragonimus is not common inside Sri Lanka, but may common in the certain part of the USA. So it gives rise to cavitary opacities. So diroperiasis is mimicking a lung malignancy. So coccidiomycosis, it looks like a tuberculosis. So there are other diseases, like other than parasitic infections, drugs and toxins also can cause eosinophilic lung disease. So commonly implicated medicines are antibiotics, NSAIDs, and the anticonvulsants. So 20% of the patients, they come acutely, and 80% of the patients, they are chronic patients. And DRESS is a well-known entity. So 1/3 of the DRESS patients have lung symptoms. And inhaled toxins also indicated in certain eosinophilic pneumonias. So sarcoidosis, there's a mild pulmonary eosinophilia. So in summary, so eosinophilic lung disease can present as acute, subacute, or relapsing or chronic. So it's very important to see whether this patient got any other organ involvement when you come to the differential diagnosis. So ask about the travel history, ask about where the patient is living, medications, recreational drug use, smoking also important. You won't see eosinophilia in each and every case of eosinophilic pneumonias. For an example, acute eosinophilic pneumonia, you won't see, at least for the first couple of days, you won't see peripheral eosinophilia. So degree of eosinophilia is important. In HES and a tropical pulmonary eosinophilia, you will get very high level of eosinophils. There are a lot of confounders, like steroid use might decrease the level of eosinophils. NSAIDs in the other way, it might increase. Radiological findings are very non-specific, heterogeneous. So you can get a clue by looking at the chest X-ray or CT. So checking stool, ova, and parasites and parasitic screening is important. The fungal sensitizations, you have to check whether the patient got any IgE response to specific fungi.
Okay, Dr.
And
Suresh,
I haven't talked about.
I think we are.
I haven't talked about the treatment. Now, treatment include antihelminthics, antifungals, steroids, and immunosuppressants. Thank you very much.
Thank you, Dr. Suresh, for that very informative and elaborative account of eosinophilic lung diseases. So we will take questions at the end of 4 lectures. So I would like to hand over the microscope to Dr. Suranga Malingam to introduce the next speaker to the session.
Thank you, Asha. Let me introduce the second speaker of the day. The world has become a small village because people are traveling from one country to other. And so this is a timely topic. The next speaker is Dr. Ruwanthi Takshila Jayasekara. She will talk about air travel with lung diseases. Over to you, Dr. Jayasekara.
Good morning, dear chairpersons. Thank you for the introduction, and thank you for coming for this forum. I'm going to talk about air travel in lung disease. I think, as was mentioned by the chair, it's a very timely topic. It's a very interesting topic as well. Why timely? Because when the COVID pandemic hit a few years ago, if you at least have a memory, I mean, we tend to forget. We tend to forget bad things very soon as Sri Lankans, but with the memory of the COVID, just 3 years back, we were in a lockdown where we couldn't go out of house, let alone travel. And when I was during my overseas training at that time, with the onslaught of COVID, the whole air travel in the world came to a halt. And after 2 years of the pandemic, when the lockdown rules were dropped down, people realized that Homo sapiens is a very social being, and you can't stay in a lockdown for long. You start yearning to open the door and travel. And as soon as the lockdown dropped, there was a huge surge of air travel. And then there was, I was working in a center which was a referral center for evaluation of people for air travel, for fitness to fly. Was being done, and there was a lot of referrals. People with all sorts of diseases were being referred to assess for fitness, and they were going through this objective assessment, where I thought was very valuable for our home setting as well. Apart from this, now air travel in the Sri Lankan setting currently is also a very timely and important topic with the current economic crisis, with a lot of migration, not only healthcare workers, but all sorts of fraternities engaging in migration, air travel. There's a lot of people who come and ask us, is my mother okay to go with me to Australia? Is my maid okay to go with me? So there are a lot of people with all sorts of disease backgrounds who come and ask, is it okay to fly? And then, again, we are promoting a lot of tourists to our country. And we have some referrals where tourists have come. Tourists with all sorts of medical backgrounds come here, and they suffer exacerbations, and they ask to go back. And then we get referrals. Is it okay for me to go back now? So with this background, I'll be going through my topic, and I'll be basically talking about our Sri Lankan experience. So again, emphasizing the importance, more than 1 billion people travel by air each year around the world. Given the rising age of the populations, so the travelers are also more elderly, and therefore will have more medical impairments. And when it comes to in-flight medical emergencies, the third leading cause is a respiratory cause. So let's try to answer this question: can I fly? So the basic outline of my talk, first I will tell you about 2 patients. The patients I will be talking in this lecture are actual referrals. And then I will talk about air travel basics, air travel with lung disease, the hypoxic challenge test, and the Sri Lankan practical experience with the hypoxic challenge test. Actually, the hypoxic challenge test was in Sri Lanka was first performed about a year ago. I discussed the proposal with my trainer, Dr. Amita Fernandez, senior consultant chest physician, and we drew up a plan, and we got the SOPs from my training center, and we went through the BTS guidelines, and we made a proposal, and we started it off. And the first Sri Lankan case was of a patient with obesity, hypoventilation, type 2 respiratory failure, and COPD who wanted to travel to Australia, which was presented at the APSR last year. And the following 16 cases I have submitted to WONCA, and I hope I'll be able to discuss it. So the 2 examples which give you an idea about what is the importance of evaluation of air travel. First one, a 71-year-old lady diagnosed with fibrotic hypersensitivity pneumonitis on MMF and pirfenidone, not on long-term oxygen, with a past medical history of dyslipidemia, hypothyroidism, severe COVID pneumonia 6 months ago. And the daughter, who is a postgraduate student who wants to go for her overseas training, has a small baby, and she comes and asks, can I take my mother with me? It's a common scenario. Next one. can she fly, because it's a long-haul flight. So next one, 62-year-old man from Israel with COPD, bullous lung disease, on short burst oxygen therapy, but not on long-term oxygen therapy, came on holiday to Sri Lanka. There he went sightseeing, sustained a bicycle injury, had a fracture, then followed by infective exacerbation of COPD going on to type 2 respiratory failure. Now he wants to fly back to Israel. So comes the question, can I fly safely with my lung problem? Why talk about air travel in a medical forum? As population ages, more people with comorbidities will engage in air travel. After COVID pandemic and lockdown, there's increasing traveling. With economic changes in Sri Lanka, people are turning for air travel. And major airlines consistently report 10% of in-flight medical emergencies resulting from respiratory conditions. And as physicians, we might have to fill this form, the MEDIF form, where the airlines might contact you if you're the treating physician of a patient with lung disease or any other illness. They will want you to fill this form, and you will have to give your objective assessment about the patient's likely requirement of oxygen and support during the flight. So therefore, we need an objective assessment. So the importance of pre-flight assessment, because if you don't have a proper pre-flight assessment in susceptible patients, it might end up with flight diversions, and it can come with a huge cost to the patient and also to the airlines, and also causes a lot of trouble to the other passengers. It helps a patient to plan the timing of the flight, and it helps to plan supplementary oxygen needs. Ordinary flights reach a cruising altitude between 25,000 and 45,000 feet. And so that is very, very high altitude. But international laws, now this law is from 1986, which stands true still. International laws stipulate that cabin pressure must not surpass that measured at 8,000 feet above sea level. That means even though the flight achieves 25,000 feet, the cabin pressure has to be maintained at the pressure level at 8,000 feet. Why at 8,000 feet, we'll discuss later. But why at 8,000 feet, and why can't the cabin pressure be maintained at what is it at sea level? That is because higher levels, so if you put higher levels of cabin pressure, or you try to give a higher pressure inside the cabin, higher levels of pressurization can decrease the energy available for other aircraft systems, and it reduces the operational lifetime of aluminum airframes. And therefore, it will lead to increased structural weight. So there has to be a compromise. So you can't give the sea level pressure inside the cabin, but you can't reduce the cabin pressure too low, because you have to consider the oxygen hemoglobin dissociation curve. And at 8,000 feet, a normal person without lung disease is able to maintain right at the upper border where the slope begins at the oxygen hemoglobin dissociation curve. I'll come to that. And also, if we put more pressure, it results in decreased fuel efficiency. Therefore, the aircraft pressure is at 8,000 feet. So what happens inside the cabin when it is at 8,000 feet? You know that at sea level, the barometric pressure is at 760 millimeters of mercury. At 8,000 feet, it is not at 760, it has gone down to 565. And at 565, even in a normal person, the inspiratory oxygen goes down from 150 to 110 millimeters of mercury. So therefore, now we know we usually inspire even a FiO2 of 21%, and this reduced barometric pressure leads to a FiO2 of 15%. And if you do, even in a person with normal lungs, the arterial oxygen will go down from 100 millimeters of mercury to even 50 millimeters of mercury, and the saturation can actually go down. However, even though this inspired oxygen level decreases, healthy subjects are able to maintain good ventilation, because they increase the minute ventilation, because they have a good ventilator reserve. However, respiratory patients may not tolerate exposure to even slight hypoxic mixtures. So if they are starting at a low saturation, or their tendency to desaturate is more, then they will become more hypoxic. And hypoxia-induced pulmonary vasoconstriction may further worsen the increase of the dead space and lead to pulmonary hypertension. It can lead to respiratory distress on air. So the sigmoid shape of the oxygen dissociation curve allows healthy individuals to ascend to moderate altitude without any appreciable hypoxemia. And even if there is some hypoxemia, you can desaturate to early 90s even, you will compensate with ventilation, increase in the minute ventilation. Beyond this altitude, the fall in the oxygen level is steep, and then you can desaturate or become hypoxic quickly. And patients with respiratory disease, they can have a rightward shift in the oxygen dissociation curve due to respiratory acidosis, which will result in decreased affinity of hemoglobin for oxygen, increasing the possibility of development of desaturation. So over several years, the British Thoracic Society has been producing statements, clinical statements. Actually, for a guideline, there is not enough RCTs, but they are practical clinical statements giving us an outline or a guidance on how to evaluate patients with respiratory disorders or respiratory diseases for air travel. So this includes, so I actually would like to ask you to read it, because it extensively gives each and every disease like asthma, COPD, pulmonary hypertension, interstitial lung disease, post-procedural, such as thoracic surgery, bronchoscopy, after pleural aspiration, after respiratory infection. What is the timing? When and how can you advise a patient to engage in air travel, and how to assess these patients? So pre-flight screening, as always, includes a good history. You have to assess the patient's symptoms, get a good history, baseline exercise capacity, what is the recent exacerbation history, and what is the flight. Is it a long-haul flight? Is the patient planning a transmit? What is the duration of the transit? And what is the flight history? Has he had any episodes of respiratory distress in flight on air before? And also, so when it comes to respiratory diseases, sometimes even a short-haul flight can be a problem, because the ascent and the descent can cause changes in the barometric pressure, giving rise to problems or respiratory distress on air in people who have not been optimized or advised properly before. Over the years, there have been, people have tried to see what are the tests, what is the best investigation for assessment, and the 6-minute walk test or the shuttle walk test has been used in the past. However, for a formal assessment, especially when you have to fill these mediforms in people with chronic respiratory diseases, a formal assessment with hypoxic challenge test, or in lay terms, a fitness to fly test, is recommended. So who should undergo this evaluation? There's a lot of criteria, or a lot of scenarios included. In general, if someone's saturation is less than 95%, that would need a proper evaluation. However, there are a lot of studies which show that a person with respiratory disease who is able to maintain a baseline saturation above 95% still has the probability of desaturating on air as the cabin air pressure drops down. So the advice is to evaluate case by case, and if there's a history of recent exacerbation, patients needing multiple medications, recent hospitalizations, then we might have to, even people with patients with a higher saturation cutoff, we'll have to do the objective assessment. And when I go to the cases, we will be able to see that. So Overall, in an overview, the lung function test, when the FEV1 is less than 50%, poorly controlled asthma or COPD, COPD patients needing domiciliary oxygen, people with exacerbations, chest wall, restrictive chest wall diseases, patients with neuromuscular disorders, pulmonary hypertension, people who have comorbidities which can worsen hypoxemia like cardiac disease or cerebrovascular disease, patients with recent respiratory tract infections, those requiring CPAP or BiPAP device like obesity hypoventilation syndrome should undergo formal assessment before they engage in flight. Then pneumothorax, cystic lung disease, patients with trapped lung, recent venous thrombosis, pulmonary embolism, they will have to be properly evaluated by a specialist and given a recommendation. Anyone who has experienced significant symptoms during previous air travel should be sorted. General contraindications: untreated ventilator failure, ongoing ventilator failure, untreated pneumothorax, ongoing respiratory infections, especially TB, and then bronchogenic cysts. When it comes to bronchogenic cysts, there's a risk of fatal cerebral air embolism because of the barometric pressure can expand these cysts and there can be rupturing. So a few words about the hypoxic challenge test. It's actually a simple test that can be done in the lung function room with a few additional material. What we need is a 100% nitrogen cylinder, a large 100% nitrogen cylinder, a Venturi mask, and oxygen. So I'll take you through the simple steps of how we do this test. The patient is, so the patient comes in, patient gives consent, and you fill the forms, you take about all the history about the destination and the previous flight details, and the patient is kept seated or semi-prone on the bed. He will be connected to the cardiac monitor, and we attach a nasal prong. That is, if we have to suddenly give him oxygen in case of desaturation, we attach a nasal prong before we start the test. Next, we have a 100% nitrogen gas cylinder that is flown through to the patient on a 40% Venturi mask at a rate of 10 liters per minute. So when you give 100% oxygen with a 40% Venturi mask, the FiO2 goes down to 15%, which is equal to the cabin oxygen pressure. We ask the patient to inhale that gas for 20 minutes while monitoring the heart rate and the saturation. Ideally, we have to do an arterial blood gas before the test to look at the PO2 and the PaCO2. Due to limitations, we do only the arterial blood gas at the end of the test in our setting. So then you monitor the patient for over 20 minutes, and during the 20 minutes, if the saturation goes below 85%, we terminate the test and we do an arterial blood gas. If the patient's saturation is maintained at 85%, we terminate the test at 20 minutes and do an arterial blood gas. Now, if the patient did not desaturate and the arterial blood gas was above the cutoff values, that is, if the PaO2 was more than 6.6 kilopascal, that is 50 millimeters of mercury, and the carbon dioxide was less than 45, I mean, if it was normal, then the patient has passed the test. So the recommendation will be the patient can engage in air flight without routine supplemental oxygen. However, if the patient's saturation had dropped down less than 85% during that 20 minutes and we had to do an arterial blood gas before, then you look at the ABG cutoff. If it is less than 6.6 kilopascal, then we go to the second part of the test. We have to see how much of supplemental oxygen the patient will require in the flight. So we go to the next part of the test where we give 2 liters per minute of oxygen and we repeat the test. We give 2 liters and 4 liters. That is the maximum because in an air flight, 4 liters per minute is what they can give in long haul flight. If the patient's carbon dioxide increases even by 1 kilopascal, then it indicates high risk of respiratory distress during travel. We actually ask the patient to avoid air travel until he is further stabilized. So this is one of the sample report forms. So asthma is the most frequent respiratory disease reported by air travelers, and 1/3 of in-flight respiratory emergencies are ascribed to asthma. So pre-flight assessment is recommended. So each of these diseases, each of respiratory disorders has to be evaluated properly and given a recommendation. So now I would like to move on to the few of the cases, the Sri Lankan practical experience of the hypoxic challenge test. So let me run through these cases. They're quite interesting. There are about 15. I'll briefly run through. 80-year-old female with a background of interstitial lung disease and bronchiectasis wants to go to the UK for a trip. It's a holiday. The baseline saturation is good at 96%. Now, actually, when the saturation is more than 95%, you wouldn't, the criteria you would say you can fly. However, because of the background ILD and bronchiectasis, and you have to fill the Mediform, it's better to have an objective assessment. And so you do the test. In this patient, she passed the test. The arterial blood gas at 20 minutes was good. So the outcome is can engage in air flight without routine use of supplemental oxygen. This is an assurance for us when we give the recommendation, as well as it's helpful for the patient. Then next one, 61-year-old male with NSIP, exacerbation of interstitial lung disease while on business travel from India. This was done recently, and with a background history of stage 4 lung cancer. The patient has to engage only in a short-haul flight. It's maybe 1 to 3 hours to India. However, the patient is on 4 liters per minute at rest with a baseline saturation of 90% while on the 4 liters per minute at rest, and we are asked to fill the Mediform. What can we say? So we do this test. So while the patient is on 4 liters per minute, he goes through the hypoxic challenge test where the FiO2 goes down to 15%, and we do the ABG, and he passes the test, and the recommendation is to use 2 to 4 liters per minute of oxygen during the flight. So it's an objective assessment. So the feedback was he had engaged in the flight without any problem. Then you have a 72-year-old female, fibrotic hypersensitive pneumonitis, not on any oxygen, wants to go to UK. Baseline saturation, 96%. But at the 14th minute of the hypoxic challenge test, she desaturated to 83%. So we went on to the second part of this test, where the saturation was maintained at 94% on 1 liter. So the recommendation was given as can engage in air flight with 1 liter per minute of supplemental oxygen. So you know the baseline saturation was more than 95%, but she desaturated. So she needed oxygen during the flight. Next one, UIP on short burst oxygen therapy. Recent infective exacerbation, wants to go to Australia. Baseline saturation good, pass the test. So this will, when you have this objective assessment and objective that you can put on the recommendation, this will help the patient, and that will have economic benefit as well. Because then you can, when you say that the patient does not need routine supplemental oxygen, then the patient's flight cost, the implications, or the logistics all change. So therefore, this was quite helpful. This was one of the postgraduate students' mothers that we did recently. So these are again the other interstitial lung disease patients that we did, where we gave the recommendations, and then we had a few bronchial asthma and scoliosis patient. Next one was a COPD patient with large bulla, interesting patient where he was on holiday from Israel. 74-year-old patient who was on short burst oxygen at home, but not on LTOT. He came here on holiday, had a fracture neck of femur, went on to have an COPD exacerbation and type 2 respiratory failure. So when he was referred, he was in a big hurry because his insurance was running out. He wanted to go back home. His baseline saturation was 87% on 1 liter, and he desaturated to 80% on 4th minute of test. So we at 20 minutes, the ABG showed hypercarbia. So we had to say he cannot fly. Risk of desaturation and respiratory distress in flight, recommend not to engage in air travel until further improvement in CO2 retention. I had to talk to the medical airline representative who coordinates these things to arrange the patient's further stay. So these are interesting cases, and we are able to give objective assessment. So there are a few more cases, and in the interest of time, I think I will wind up. So basically, because hypoxic challenge test is a new simple test that can be done in our local setting, I wanted to share my experience and highlight the importance of evaluation, of formal evaluation of patients with lung disease, respiratory conditions, and give advice on air travel. Thank you.
Thank you, Dr. Jayasekara, for your wonderful talk. And the questions will be asked at the end of the symposium. And we'll move on to the third talk.
So the third speaker to the session is Dr. Seva Duwen. He's joining us from Singapore. He's the head of and a senior consultant in Department of Respiratory and Critical Care Medicine, Singapore General Hospital. Dr. Seva Du, please join us.
Good morning. I would first like to thank the Sri Lanka College of Pulmonologists for the kind invitation today. I would have loved to join physically, but due to logistic reasons, I'm delivering this talk via pre-recorded lecture. I've noted financial disclosure relevant to this talk. Pulmonary hypertension is divided into 5 major groups for clinical classification purposes. In addition to hemodynamic differences, these groups encompass a broad range of underlying conditions with varied prevalence and therapeutic approach. Group 2 and Group 3 conditions are by far the most common causes of pulmonary hypertension. The current diagnostic algorithm in the workup of pulmonary hypertension also needs to consider the severity of the underlying cardiopulmonary comorbidities. There has been minimal change to these classifications in the 6th World Symposium held in 2019. Some of these changes include the addition of PH long-term responders to calcium channel blockers as a distinct subcategory in Group 1 pulmonary arterial hypertension. In addition, Group 3 pulmonary hypertension due to pulmonary disease, lymphangial leiomyomatosis has been repositioned into this group. Concurrently, obstructive sleep apnea has been removed from Group 3 pulmonary hypertension, as this condition alone is rarely a cause of clinically significant pulmonary hypertension. Pulmonary hypertension has historically been defined as a mean pulmonary arterial pressure of 25 mm mercury and above, as measured by right heart catheterization. The 6th World Symposium on Pulmonary Hypertension in 2018 proposed a new hemodynamic threshold of a mean PAP of more than 20 mm mercury, and this has been endorsed by the European Society of Cardiology and European Respiratory Society in 2022. It's important to note that the finding of an elevated pulmonary arterial pressure in isolation is insufficient to determine the underlying mechanisms leading to pulmonary hypertension. Elevated pulmonary arterial hypertension does not imply a primary pulmonary vasculopathy and may occur in a setting of elevated cardiac output in certain physiological states such as exercise and pregnancy, as well as non-cardiopulmonary disease states such as liver disease and anemia. For these reasons, right heart catheter measurements of cardiac output and pulmonary arterial wedge pressure and calculation of pulmonary vascular resistance are integral in diagnosing pulmonary hypertension and determining its hemodynamic classification. The following hemodynamic classification is the current definition used to separate the various categories of pulmonary hypertension. The presence of a mean pulmonary arterial pressure of more than 20 mm mercury and elevated pulmonary vascular resistance of 2 Wood units or more, in conjunction with a wedge pressure of less than 15 mm mercury, is used as the hemodynamic definition of precapillary pulmonary hypertension. a wedge pressure of more than 15 millimeters mercury designates post-capillary pH, i.e. pH caused by left heart disease, which can be further divided into isolated post-capillary forms where the pulmonary vascular resistance is less than 2 Wood units, or combined pre-capillary and post-capillary forms where your PVR is more than 2 Wood units. The current hemodynamic definition also introduced the concept of using exercise pulmonary hypertension to define the pH in patients with early pulmonary vascular disease. In patients with early pulmonary vascular disease, the PVR may be normal or mildly elevated at rest, but may change during exercise with a steep increase in the mean PAP, reflected by a mean PAP to cardiac output slope of more than 2 millimeters mercury per liter per minute. A number of reasons have led to the revised change in the hemodynamic definition of pulmonary hypertension. In a meta-analysis of right heart cath data from normal subjects, their resting mean PAP was 40 millimeters mercury, with a limit of 20 millimeters mercury using 2 standard deviations above the normal value. In addition, large cohort studies have clearly established increased mortality and risk for hospitalizations for mean PAP between 21 to 24 millimeters mercury, or previously the so-called borderline pH. The new threshold of pulmonary vascular resistance of 2 or more Wood units is also more accurate in predicting mortality in patients with pulmonary hypertension compared to the previous threshold of 3 Wood units. The updated definition will lead to an increased case finding in patients with pulmonary hypertension. In this cohort study of 87 patients from University of Michigan with a right heart cath reading of mean PAP of more than 20 millimeters mercury, we see that 29% of the patients with mean PAP of less than 25 millimeters mercury will meet the criteria of pH when you use the PVR of more than 2 Woods. In addition, 25% of patients with mean PAP of more than 25 will be reclassified as having pH when a PVR of 2 Woods is used instead of 3. This has the potential to identify patients with pH at an earlier stage of the disease and hopefully permit introduction of therapeutics at an earlier time frame with the potential to improve outcomes. However, we need to be cognizant that the current therapeutics in pulmonary hypertension have not been proven to be of benefit in patients with mean PAP between 21 to 24 millimeters mercury, because all clinical trials have universally used a mean PAP pressure of more than 25 as an inclusion criteria before the definitive change at the 6th World Symposium of pH. I will not go through in details regards to the initial workup of pulmonary hypertension. It is important to note that in patients with suspected pulmonary hypertension, we first need to evaluate for significant lung and cardiac disease, as the presence of these conditions may not necessitate further assessment, especially if a screening transthoracic echocardiography shows low probability of pH. If the screening pH is high, further assessment for group 4 pH is recommended. If pulmonary arterial hypertension or CTEPH is suspected, all patients should receive a fast-track referral to a pH center for further assessment and management. I will next discuss the current recommended approach to the management of pulmonary arterial hypertension once a diagnosis is confirmed. The use of a risk stratification tool to identify patients who are at increased risk of mortality or disease progression will inform the initial combination treatment options, with higher risk patients being started on upfront doubled therapy. Identification of patients with significant cardiopulmonary comorbidities will in contrast lead to recommendation to start on monotherapy, as the risk of clinical deterioration will be higher with combination treatment. The aim of the initial therapy is to bring the risk stratification in the next subsequent visit to a low-risk strata using combination treatment. This is the 3-strata risk model proposed by the European Society of Cardiology in 2016. It is a multi-parametric model using patients' symptoms, functional class and capacity, laboratory and echographic markers of right heart strain, other forms of cardiac imaging, and lastly hemodynamic parameters to assign patients in their first visit to a low, intermediate, or high-risk strata. Other risk models have also been derived using registries from Spain, the United States, and Sweden, which I will not be going through in today's talk. The current treatment options with selective pulmonary vasodilators are limited to the three established pathways targeting the nitric oxide, endothelial, and prostaglandin pathways. However, there are novel pathways in the pipeline which have been evaluated and have the potential to be added as part of a combination treatment strategy for patients who remain in intermediate high risk despite conventional treatment. This is the treatment algorithm proposed by the European Society of Cardiology. For patients with no significant cardiopulmonary comorbidities, a low intermediate risk grouped patient will be recommended to start with combination dual treatment with an endothelial receptor antagonist and phosphodiesterase 5 inhibitors. In high-risk group, the addition of intravenous or subcutaneous prostaglandin agents are recommended to further reduce mobility and mortality. In contrast, if a patient has significant cardiopulmonary comorbidities, it is advised to approach the treatment with selective pulmonary vasodilator in a more judicious fashion. Monotherapy with phosphodiesterase inhibitor or endothelial receptor antagonist is recommended, and treatment is subsequently titrated in an individualized fashion. The recommendation of upfront combination treatment with endothelial receptor antagonist and phosphodiesterase 5 inhibitor in patients with no significant cardiopulmonary comorbidities are based on meta-analysis of multiple clinical trials that showed this approach reduced clinical worsening, hospitalization, and occurrence of serious adverse events. Hence, the use of upfront initial combination therapy with endothelial receptor antagonists and phosphodiesterase 5 inhibitors for low to intermediate risk groups has been given a Class 1B recommendation for Group 1 PAH patients. Upon initiation of treatment based on the patient's initial risk strata, the European Society of Cardiology recommend titration of treatment and subsequent outpatient visits with a new 4-tiered risk assessment tool. This uses 3 parameters of functional class, exercise capacity, and brain natriuretic peptides to stratify patients into low, intermediate high, and high risk groups. The use of this new 4-tier risk assessment tool at follow-up will improve the ability of the clinician to better discriminate the survival probability in the previous intermediate risk group and help guide further adjustments of therapy. Selexipag, an oral selective prostacyclin receptor agonist, has been tested in patients on the background of treatment with endothelial receptor agonists alone or in combination with phosphodiesterase 5 inhibitor. In this Griffin trial published in NEJM in 2015, the use of selexipag reduced the composite endpoint of death or complication related to pulmonary hypertension. As such, the addition of selexipag to ERA and phosphodiesterase 5 inhibitor has been given a Class 1B recommendation by ESC. The strategy of replacing a phosphodiesterase 5 inhibitor with rosiguat, a soluble guanylate cyclase stimulator, was tested in a group of patients at intermediate risk of pulmonary hypertension. In this prospective randomized controlled open-labeled 24-week trial, patients were randomized to the arm where PDE5 was switched to rosiguat compared to the arm who maintained a phosphodiesterase 5 inhibitor with or without the endothelial receptor antagonist. The primary endpoint was clinical improvement at week 24, defined as the absence of clinical worsening and an improvement in 2 out of the 3 criteria using 6-minute walk test, WHO functional class status, as well as NT-proBNP. The result of this trial showed that the primary endpoint was reached in 41% in the arm treated with rosiguat versus only 20% in the arm maintained on phosphodiesterase inhibitor. In the various defined secondary endpoints, the rosiguat arm showed an improvement in 6-minute walk distance, improvement in WHO functional class status, reduction in NT-proBNP, and reduction in time to clinical worsening. Switching to rosiguat from phosphodiesterase 5 inhibitor treatment, both of which act upon the nitric oxide pathway, could be a strategic option for treatment escalation in patients with pulmonary arterial hypertension at intermediate risk of 1-year mortality, and this has been endorsed as a Class 2A recommendation by the ESC. Besides the agent used in the previous 3 pathways, new targets of pulmonary arterial hypertension therapy has been extensively researched. Pulmonary vascular remodeling affects all layers in the vessel wall and is driven predominantly by enhanced proliferation and diminished apoptosis of the endothelial and smooth muscle cells. Recent research has highlighted the role of altered signal transduction by members of the transforming growth factor beta superfamily, including bone morphogenetic protein receptor type 2, activin receptor type 2A, to name a few. A shift towards proliferative and anti-apoptotic signaling by these TGF beta superfamily members is thought to be a prominent mechanism driving pulmonary vascular remodeling in patients with pulmonary arterial hypertension. Sotatercept is a first-in-class fusion protein consisting of the Fc domain of the human IgG linked to the extracellular domain of human activin receptor 2A, which acts as a ligand trap for selected TGF-beta superfamily members. In animal models of pulmonary hypertension, sotatercept inhibited cell proliferation, promoted apoptosis, and elevated inflammation in the vessel wall, leading to reverse remodeling and restoration of vessel patency. In this phase 3 randomized controlled trial of sotatercept in treatment of pulmonary arterial hypertension, the addition of sotatercept in patients with WHO class 2 or 3 and stable background doses of selective pulmonary vasodilator was compared to the controlled arm. The primary endpoint of change from baseline in 6-minute walk distance at week 24 was significantly better in the sotatercept arm, with a Hodge-Lehmann location distance shift of 40.8 meters in favor of sotatercept group. In addition, treatment with sotatercept for 24 weeks significantly reduced the right heart size and improved the right ventricular function and hemodynamic status in patients with pulmonary arterial hypertension. As such, it has been proposed that sotatercept can be incorporated in future treatment algorithm. In low or intermediate low-risk group, sotatercept may be considered at follow-up if the 4-strata model showed unfavorable progress or hemodynamic profile. In the intermediate high or high-risk groups at follow-up, sotatercept may be added as an alternative to prostacyclin analogs on basis of hemodynamic profile and patient preference. In the last segment, I would like to briefly touch on the advances in Group 3 pulmonary hypertension. In the latest ESC 2022 guidelines, the hemodynamic classification of Group 3 pulmonary hypertension uses the same mean PAP definition of more than 20 mm mercury. In addition, a new severity classification of a pulmonary vascular resistance of more than 5 Wood unit has been used to define severe PH in lung disease. This is based on data from various registries such as Compara, demonstrating that both the mean PAP and PVR are strong predictors of survival in chronic lung diseases associated with pulmonary hypertension, with the PVR of more than 5 Wood units discriminating mortality in these registries. For the treatment of Group 3 pulmonary hypertension with pulmonary vasodilator, the past results have been nothing short of disappointing. Initial promise of improved hemodynamic profile in patients with COPD using phosphodiesterase 5 inhibitor did not translate to similar improvement in other Group 3 conditions such as idiopathic pulmonary fibrosis. The use of endothelial receptor antagonists had shown signals of increasing mortality in interstitial lung disease as well as increasing the exacerbations. Similarly, the use of rosiguat in interstitial lung disease has been associated with increased respiratory-related adverse events and death. However, there has been some promising news for Group 3 pulmonary hypertension when inhaled treprostinil was tested in patients with interstitial lung disease with pulmonary hypertension as defined using the old hemodynamic definition of mean PAP of more than 25 mm mercury and PVR of more than 3 Wood units. In the increased trial published in NEJM in 2021, inhaled treprostinil was added in the interventional arm and compared to a controlled arm treated on the background treatment with antifibrotics and or selective pulmonary vasodilators except those on prostacyclin pathways. At the end of 16 weeks, the use of inhaled treprostinil showed improved 6-minute walk distance, reduced anti-proBNP levels, and led to fewer clinical worsening. Encouragingly, adverse events will also not increase with the use of inhaled treprostinil. This has led to the FDA approving inhaled treprostinil as the first pulmonary vasodilator approved to be used in ILD with pulmonary hypertension. I've come to the end of my talk today. Some take-home messages. The definition of pulmonary hypertension has been refined with the change in the mean pulmonary arterial pressure and pulmonary vascular resistance values to better capture patients at increased risk of mortality. The treatment strategy is heavily dependent on the initial 3-strata risk model and titrated based on the new 4-tier risk assessment tool. Use of upfront combination therapy is recommended, and subsequent treatment options are titrated to reach the low-risk strata and follow-up. New agents targeting novel pathways are soon to be made available and showed promise in adding to our existing options in the treatment of pulmonary arterial hypertension. With that, I would like to thank everyone for your kind attention.
I would like to formally thank Dr. Sevaduvin, though he is busy in his hospital. So I would like to hand over my microphone to Dr. Suranga to introduce next eminent speaker, one of the pioneers in respiratory medicine of Sri Lanka.
Yes, our fourth and the final speaker of the day, of the symposium, is Professor Dushantha Madagedara, and he does not need any introduction, but as a formality, he's chair professor of medicine, Wayamba University of Sri Lanka, and he's a consultant respiratory physician, respiratory disease treatment unit, and National Hospital, Kandy, Sri Lanka. And he will talk to you on novel approaches in the management of pulmonary embolism. Over to you, Professor.
Suranga, this lecture was actually to be given by the Dr. Yashi from Bhutan because of some problem in the country in the current epidemics. He could not able to make it, so I have no other option to do myself. Right. Anyway, you have listened to the several areas of respiratory interest in the last 3 lectures, and I will take you to the different arena, what you are to the day-to-day practice. This is what we see in our day-to-day practice. It's not an uncommon problem. So novel approaches in the management of pulmonary embolism. When you talk about the pulmonary embolism, it is not an uncommon problem. It's a common, and as well as a fatal if you miss the diagnosis at the initial stage. Despite advance in diagnosis and management, unless you have clinical suspicions of pulmonary embolism, you may miss the patient. And what is happening theoretically is a thrombus migrate from the venous circulation to the pulmonary vasculature, lodges in the pulmonary vascular arterial system, giving rise to the clinical symptomatology of pulmonary embolism. It can vary from the acute pulmonary embolism to the massive or the fatal pulmonary embolisms, depending on the size and the other various factors are involving. When you talk about the epidemiological aspects of pulmonary embolisms, pulmonary embolism and the deep vein thrombosis is the 3rd most frequent acute cardiovascular syndrome behind the myocardial infarction and strokes. And there's a 10 million cases per year was recorded in the world literature, and annual incident rate of pulmonary embolism ranging from 39 to 115 per 100,000 population, and the deep vein thrombosis ranges from 53 to 162 per 100,000. These two closely associated, except very few situations. And it is an observation now in the country to country, the incidence and the prevalence is varying. Actually, it is due to the differences, the accurate diagnosis, rather than in actual. When we were the registrars in medicine and the junior doctors and house officers, we hardly saw single cases of pulmonary embolisms. But in my day-to-day practice per month, we diagnose several cases of pulmonary. That is also just a theoretical thing what we learned when we do the MD medicine those days. Now we diagnose several per month, and at least 1 or 2 cases at most of time, at any given time in our clinical practice. And it's a 15% of the all it's a reason for 15% of post-operative mortality. This particular graph shows that how the annual incident rate is varying in the different countries, but the case fatality rate is actually reduced. But the early diagnosis, proper management have reduced the case fatality rate. And again, so the definition is an obstruction of the pulmonary artery or its branches by a material, may not be a thrombus, maybe a tumor or fat that originate elsewhere in the body, coming to the lung pulmonary vasculature and causing. It varies from the acute to chronic and even the massive. When you talk about the pathophysiological basis, it is mainly 2 extremes. One is a respiratory consequence, where your blood vessels are blocked. your pulmonary vasculature blocked, you have no perfusion, but you are having the parenchyma with oxygen, but it cannot diffuse. So even diffuse, it cannot take it. So that can cause a hypoxemia and alveolar dead space and lead into naturally hyperventilation. Other part, when your vessels, pulmonary vessels are blocked, there are various mechanisms occur due to obstruction and the resistance of the pulmonary vascular vasoconstriction causing the right ventricular pressure overload and consequences of acute as well as chronic changes of thromboembolism. If you just to show this graph, you say that when the vessels are blocked, when your pulmonary vascular pressure is high, when your right ventricular, the load is increased, the pressure is lower, it has various physiological events, finally leading to the obstruction of the blood flow to the left side, giving rise to the death. It has many physiological situations. I may not be able to give you the full detail because of time factor. There are many risk factors I recognize. There are some risk factors, the odd ratio more than 10, and the same way the weak risk factor from the less than 2. And like, for example, after post-surgically, after fractures, orthopedic surgery, you have more higher tendency to, same way the opposite of it. If you are bedridden for 3 days for some other reason, or even pregnancy with a mobile patient, you will have less risk. So these risk factors are varying. With there will be other associated comorbidities. The symptoms varies from the asymptomatic to the acute sudden death. We are starting from the breathlessness, very important, having a chest pain, palpitation, hemoptysis, or acute sudden collapse, or the progressive breathlessness, particularly in the chronic pulmonary embolisms, are very important to suspect. How do you going to assess this patient? Now, when the patient comes with the breathlessness and cough, or with the hemoptysis, there are many differential diagnoses. So you need to find that the given history of symptoms and the given background of having the deep vein thrombosis, then you have to see that is this case is fitting for a pulmonary embolism. So that's you get the risk, as what you call pre-test probability or clinical pre-test probability. Even after some basic investigation, we come to post-test probability. So we use the Geneva and the Wells criteria for that. What they're really looking for is a previous history of pulmonary embolism or DVT with the effects of the pulmonary embolism system like increased pulse rate, hypoxia, and the symptoms as a given predisposed like a lung cancer. So we'll get everything together and then the scoring, and then say is a low or intermediate or high probability or the high risk, pulmonary is unlikely or likely, going through the scoring systems. And the Wells criteria is the same thing, considering the total clinical picture, giving the different criteria and getting the low, intermediate, high risk factor. I am not going to read in this, I will obvious thing. When someone coming with these symptoms, you may be over-investigated. So we have to know about pulmonary embolism rule out criteria. So that means it's less likely. So then you can't go for a CTP or D-dimer in a country like where we have a economic burden and the minimal resources. They have to know. Then what you call the Wells criteria is the opposite of it. The younger person coming with otherwise normal, pulse rate is within normal, saturation normal, and nothing else, no risk factor. Then it's less. But there's nothing called absolute. Don't think that a young patient can't have pulmonary. I have enough patients. So take this as a clinical scenario, but then you decide to go ahead or not. How do you go and diagnose? More simple clinical percentage, which I have already explained, and then the hemodynamic criteria, hypoxia and low blood pressure, tachycardia, etc. Syncope is very important, particularly massive one. If it was a young patient or someone, I had a syncope, but nothing else to be explained, pulmonary embolism should be there to be also. And the hypoxemia and hypercapnia, which I already explained. And most important to recognize assessment of hemodynamic stability. If some patients there with the typical clinical history and high probability, if you find the patient, the blood pressure is very low, less than 90 millimeter mercury with more than 50% or the more than 40% reduction in blood pressure, in features of hypotension or right ventricular failure, they had to suspect. They can present us with a sudden death or cardiac arrest, or they can have the features of obstruction of the right ventricular outflow, or you have progressive hypotension. This patient had to be recognized immediately because treatment has to be started then and there. We cannot wait. So D-dimer is a common test. What we do is can begin acute thrombosis, and it's a high negative predictor. The negative D-dimer could be less likely, but nothing absolute. Nothing absolute. I have enough pulmonary embolism patient, D-dimer is negative. I said, no, this is pulmonary embolism. Go ahead. But you take it as a positive thing, but do not just strictly adhere to this so-called negative one. No, nothing like that in clinical medicine. But if you get it as a positive response, depending on the clinical case, And then the D-dimer can be increased, the infection or malignancy. There are so many causes. We go to the patient properly, clinical, then you know, is it due to this? And the titer. Here, enough patient rate of more than 5,000. You cannot explain with a simple CRP of 20, the D-dimer of 5,000, then you know it's unlikely to impact. So go to the total patient. And it is actually, if you do the ELISA test, they say that diagnosed sensitivity is more than 95%. But negative ELISA D-dimer can exclude period. This is just broadly, I told you nothing called absolute, but I told you can be D-dimer negative and inner pulmonary embolisms. Chest X-ray, this is a very basic of investigation, may not be in the high stuff in the well-developed country. I have diagnosed so many cases of pulmonary by just looking at chest X-ray, like it used to be Westermann or Plisners or the Hampton sign or small pleural effusion, atelectasis, loss of volume. Chest X-ray give you the big, very important clue, it's a pulmonary embolisms. We have diagnosed. If it's a prominent pulmonary artery, unexplainable, there's a almost dark in the lung, the right upper. Is it pulmonary embolism? You have to be careful. You can't miss it. That's what is freely available. And the CTP has no doubt. Is the CTP is the most important investigation. We go ahead with a particularly intermediate and high probability, and we diagnose it's occlusion. Even CTP may be negative in the small embolus, got a distal lodge, which can be already when you do the CTP, it almost dissolved. So just a typical clinical history, even a CTP negative, there could be a pulmonary embolism. Although the guideline may not mention that. They may see few, but we see many. Arterial blood gas will be helpful only in the situation where the clinically it is tally, but not otherwise. ECG is very important for sinus tachycardia, S1, T1, Q3, and any arrhythmias, anything you can get, even right ventricle straining pattern, many changes you may get in the ECG. Lung scintigraphy is not practically available in our practice, except the very selected cases. Will be helpful situation where you cannot do the CTPA, and then this will be helpful, but in our practice, really we may use. Okay. And particularly the single photon emission CT SPECT has excellent sensitivity and specificity. Pulmonary angiogram is just a history now. Earlier, 15 years or 20 years ago, we ordered the pulmonary angiogram. Now, because CTPA, we hardly want to do the pulmonary angiogram currently. Echocardiography is again the very important test in our practice. We get RA-RV dilatation, pressure grading in suspected case. Unless there's another reason to explain it, it is very important for us. We suspect it. We go ahead and do it. But well developed and may not be. But it is our practice really helpful. We get the dilatation. Compressive ultrasonography is a very important. Another one is actually our radiology colleagues are helping us to do that. If you find the thrombus in a DV, the deep vein thrombus is the proximal one above the knee with the clinical history. It's highly supportive of this one. And when someone is there with the typical clinical and the imagine what you call echo or the X-ray, then you have to do the risk assessment. Again, the same thing, go for age, sex, as a comorbidities, then you can get the scoring, and then you get the risk stratification. There's a class 1, class 2. These are helpful for getting how urgency and how we're going to follow up the patient. If someone is having a suspected case of pulmonary in your history, bedside the echocardiography is really helpful. If you find the right ventricle dysfunction, yes, then go ahead with the CTPA. If a D-dimer will be highly supportive, and if it's a positive treatment negative, look for other possible causes. Still, remember, it could be a pulmonary embolism. And if someone is there, the pulmonary, we need to treat it. So most important, hemodynamic and respiratory support, where the oxygen treatment is usually mandated if a patients are hypoxic, and sometimes we have some non-invasive ventilation, like high flow oxygen. We use high flow oxygen. It's freely available after COVID with us. And NIVs we use. And the pharmacology treatment, acute right ventricular overload, we use a volume optimization. If it's a hypotension, we like volume. If it's a we use it to maintain the vasopressor, so inotrope. If blood pressure cannot maintain, then naturally, if your pulmonary artery is blocked, nothing will go to the left side. Your cardiac output naturally will low. So you have to give the fluid, but remember there's a block. Even whatever you give, you have to simultaneous parallel managements are mandatory, and you use a dobutamine. In countries where there are more supporters of mechanical circulatory support, like in ECMO, it is hardly available, but limited in our services. In Ragaman and Colombo, I ordered ECMO for 5 years before. I got nothing yet, even at the COVID time. Initial anticoagulation is essential. Anticoagulation is recommended without delay in the patient for high or intermediate. Do not delay. You cannot delay. You have to start then and there. You can use a low molecular weight heparin or pondaparinx, or you can use a non-vitamin K antagonist in the oral with the support. I usually get to my hematologist to help me on this thing, but they are the expert on this particular. You have to apixaban or inoxaban or rivaroxaban, we can get their support and maintain INR between 2 and 3, roughly about 2.5. But be careful when you use a non-vitamin K and this oral anticoagulant where there are severe renal failures, pregnancy, lactation, and antipolypsipon. I usually get their support, our hematology, and the multidisciplinary team, our cardiologists, our sales, as well as a vascular surgeon, and whoever important management needs to be discussed. We get their opinion, but we must respect our expertise. And if a patient having the hematologically unstable, the hematologic deterioration, then we have to use a reperfusion treatment, what you call rescue thrombolytic therapy, use a streptokinase or TPO, whatever. And not only all the patients, in the patient, the selected crowd, if some situations where we cannot use a rescue thrombolytic therapy, there are surgical things. There are surgical embolectomy and percutaneous catheter. We put a catheter through the pulmonary artery, we can break the clot. There will be a small one blocking the peripheral branch, but saving the life is more important. And we may use a situation where but remember the routine use of primary systemic thrombolysis is not indicated. Very, very important to know. Only the selected patient, where the patient deteriorating clinically and then the severe feature. And imperial vena cava pill test can be used in the acute pulmonary embolism where there's absolute contraindication to anticoagulant. I had a lady, I could talk about 20 years before. She had a multiple young lady where she had a lot of problems. So we had to get our surgeon, thoracic surgeon to do and vascular surgeon to do the imperial IVC pill test. So the removing was another difficulties, that one. And I had to consult the thoracic surgeon in Colombo that time. And particularly IVC filters available for recurrent pulmonary embolism, but again, routine use of IVC filter is not indicated, but only selected recurrent patient where you cannot use anticoagulation, then you have to think about. And early discharge and home treatment in the selected the minor patients, that means they have the less risk, but after going through the total assessment. This will give you some little idea of patient without hemodynamic stability. They are otherwise okay. You assess the clinical probability of pulmonary embolism, Wales or Geneva criteria. Then you do the low probability or low intermediate clinical, go do the D-dimer test. If it is negative, no treatment, and nothing absolute. I tell you, I have to give you some guideline for a lecture, nothing like that. But you have to see the patient overall thing. But according to guideline, that is what they. If it is positive, go ahead with the CTPA, and positive, treat it. If it's negative, again, no treatment, but no, you have to go to the patient again, look for all the possibilities, because you may get another bad embolus tomorrow. If there's a high clinical probability, you can go ahead with the CTPA and treat. If it is positive, negative again, you have to go to total assessment. If emergency department, we are with a very high risk pulmonary, it's a high probability case. I told you there's no delay in anticoagulation, enoxaparin. If there's no contraindication, then and there you have to start it, and then see the hemodynamic instability. See, if there's a yes, then you have to go for reperfusion treatment or streptokinase. If it is no, then reassess the patient by doing 2D core, right ventricular dysfunction, right ventricular pressure. If everything is more present, again go for a troponin. This troponin is another very important investigation to be positive. Then you have to go to reperfusion. That means there's a significant ischemia to the myocardium, and the lungs should be there. And if it is not there, then again you have to go to total assessment, and then you have to treat the treatment. And particularly this is a high-risk patient, high probability case. I told you the systemic thrombolysis, if the situation where you cannot use, you need to get your surgical support, vascular surgeons and your thoracic surgeon, pulmonary embolectomy and percutaneous catheter 1. Then after stabilizing, simultaneous anticoagulation. If it is indicate there are different type of anticoagulation we can use according to different clinical setting, and you continue the anticoagulation with the support of our hematologist. And the treatment of intermediate or risk pulmonary embolism, where the parental or oral anticoagulation can be given. Patients, if an intermediate high-risk group, if they deteriorate when you're following with anticoagulation, they have to you go for vascularitis persistent, you had to go to streptokinase or surgical control. So remember, the routine primary reperfusion are not indicated in the intermediate, but if they deteriorate, you had to go for routine the reperfusion treatment, which I already explained to you all. So rescue thrombolytic therapy is an alternative for that, and that is only for the patient who are deteriorating. And the management of low risk pulmonary embolisms patient, the early diagnosis there, then you can use anticoagulation for you to discharge them. In a situation, then you have to go to the patient, there's less risk. There are the death or serious complications after you discharge, and go to the other comorbidities and aggravating. If there are, you cannot. If there's nothing, you can consider, and the proper outpatient follow. So if you arrange all three, then you can discharge. Chronic treatment, the patients who are on pulmonary embolism, you have to continue anticoagulation. And if particularly recurrent venous thromboembolism, again anticoagulation must. How long to give anticoagulation? It's a very important other factor. Every day we have to discuss this matter. If a patient having all patient pulmonary embolism, 3 months is must. But if there's a first pulmonary embolism or the VTE, venous thromboembolism, secondary to the major transient or reversible risk factor, then 3 months or little longer than 3 months may be enough. But you may give indefinitive duration, the recurrent venous thromboembolism, antiphospholipid syndrome, no identifiable risk factor, cancer. You don't know what make it goes, provided that you have extensively investigated to rule out all possible secondary causes. They are indefinitive. We may give extended oral anticoagulation for 6 months or little beyond using the non-vitamin K analogs in the situation where rivaroxaban or otherwise, and to some patient depending on the assessment risk factor. But then you have to carefully monitor renal, liver, and the bleeding risk. Management pulmonary embolism patient, the cancer, the malignancy, you can use a low molecular weight heparin, and you can use the non-vitamin K analogs, and you may get extended period, which I already mentioned. And pregnancy, in the pregnancy, it's not only, even yesterday I got a call from my team from the Candy. I had a pregnant patient with pulmonary embolism. You can use the low molecular weight heparin. Again, if they're getting high grade or deteriorating, naturally you go for thrombolysis and surgical embolectomy after discussing with the relevant expertise. And again, we are not giving non-vitamin K analogs. Amniotic embolism, also you have to suspect any patient, pregnant lady coming with features of thrombotic embolism. And again, same thing which I mentioned here, the same because time pattern, I may not go to this graph. Stage follow-up patient after pulmonary embolism. So you get it, patient acute, you have to start anticoagulation, you have to, after your initial assessment, go 3 to 6 months, assess the patient, 3 months or 6 months, go to the clinical history, lung function, relevant 6-minute talk test, so on. If there's no dyspnea, then you have to reassess and go to the patient, decide to when to stop it. If you have dyspnea, yes, then naturally you go to echocardiogram, and the lung function has no pulmonary hypertension, nothing else. Then you have to find the other alternative cause for this breathlessness thing. If it is there, you have to assess the cardiac status, everything. You have to decide what you're going to do. Now, what is most important, I just mentioned pulmonary embolism, look for why they go to pulmonary. There are many thrombolytic, hyperviscosity, so many conditions that you have to use your medical knowledge and the respiratory knowledge to find the particular etiology. Then treat the etiologies I did mention here, that is number one. Treat the embolism, treat the etiology, and manage the patient as a whole, look at address all associated comorbidity, but do not allow them to go into chronic thromboembolic lung disease leading to pulmonary hypertension. I'll stop there and I will answer what your question arises during the discussion. Thank you.
Thank you, Professor Madagedara, for your wonderful and comprehensive talk. And now the floor is open for questions, and we can allow 2 or 3 questions.
Going to this Hajj, because a lot of chronic patients all want to go to Hajj these days because of the after COVID. So it is actually routine practice. We do a lot, and I get my senior registrar. We follow the UK guideline, British guideline, and we do the same thing what you said. We usually get it, so it's actually we do a lot. We do, I can remember the last 25 years I'm doing that. It is, because it's a routine practice, because all the COPD, I don't remember, so the lot of, particularly the, not Sri Lankan moving, or even as you said, the foreigners who comes here and then they have problem giving. So we do practice, because it's not that difficult. Yes. And we have to give, as you said, the medic 4, we have to go clear instruction. If you go wrong instruction, we are in crisis. If you are good, so I have to practical assess. We do actually. We do a lot of pulmonary respiratory fitness for air travel. And actually, I have include similar lecture about I think 4 or 5 times for respire session, and keep our people to update it because of that purpose actually.
Any more questions?
Yeah, so one question from Ruanti. So the gold guidelines says in patients with COPD, if the saturation is more than 95, they could be allowed to fly without any further assessment. Would you agree or disagree with that? So in your studies, I have seen that you have performed hypoxic challenge test on patients who have saturation of more than 95 also.
Yes. At the moment, that's how even the BTS clinical statement says, if the patient's baseline saturation is 95%, they can be deemed fit for travel. However, there's a lot of evidence coming that when they have an underlying respiratory disease, that even when their baseline saturation is more than 95%, they still can desaturate when the cabin pressure goes down. So then we have to, that's why I said like you have to assess the clinical background. If it is a stable COPD, then that's fine. But if the patient has had recurrent exacerbations and is on, has recent hospitalizations, then we will have to do the objective evaluation. And as I showed, we have had patients where the baseline saturation is fine, but when we do the test, they actually, they can deteriorate. So they will be on the, I mean, they will, it's like they're on the fence. I mean, they can deteriorate quickly. They can go down the oxygen hemoglobin dissociation curve quickly. That is because of that, the shift of the oxyhemoglobin curve can be to the right side chronically with ongoing chronic respiratory acidosis. So
they have tried to oversimplify the recommendations. So
yeah, up to actually the guideline that I mentioned was 2021. Before that, there has been in 2011, 2002. In those studies, actually, they don't mention this hypoxic challenge test. They go by the 6-minute walk test or the shuttle walk test. Then afterwards, they have found that the formal assessment is needed for proper prediction recommendation.
Can I ask a question?
Yes.
My question is Professor Madhukar. Thank you for that excellent overview. There are instances where you mentioned the consequence of recurrent thromboembolism and chronic thromboembolic pulmonary hypertension. So there are instances where patients who are hemodynamically stable, but they have thrombi in the main arteries. And we often have referred to radiologists, interventional radiologists for clot aspiration, clot retrieval, and procedures like that, which sometimes happen at NHSL. Are there any criteria where we should be guided by instances like that, where where we refer patients to interventional radiologists?
But actually, I was reading a little about this presentation. Now, what is important thing is that I had a patient last week. The patient was reported by a physician, my younger. She was one of my trainee. That particular lady had a breathlessness, so I think 2 months. 2 months. Breathlessness, a little chubby patient. I think nothing else he had it, and the investigations normal because of my clinical examination history, I could not find any other reason for explaining breathlessness, including diaphragm. If you have diaphragmatic paralysis, you actually end up with a breathlessness. So then the D-dimer, everything is nothing. Okay. So then for me, it is a pulmonary embolism. So we had a massive thrombus blocking not only 1, 2, 3 vessels. This one. Now the interventional, there's a large thrombus. We start inoxan or we treat it like a normal case. Now my actual experience for the last 25 years treating this pulmonary embolism, I get a support of the vascular surgeon. I remember one. I actually consulted even professor of surgery in Colombo sometime before with the multiple emboli and the IVC pill text. And then the vascular surgeon actually I usually consult, and then they used to do the embolectomy and this one. Interventional radiology actually I haven't contact. I could not find anything.
We are not sure whom to write with. It's a vascular surgeon
I usually get there.
radiologist.
And even not a thoracic surgeon. Thoracic surgeon, they say get the vascular surgeon, then they combine and jointly manage it.
sometimes I think the interventional radiologists do these clot aspirations.
Yeah.
I don't know if there's anybody in the audience who can share their experience.
They may put us.
No, because the prevalent, recurrent.
Yeah, definitely. Submissive.
So there is some ongoing studies on submissive PE, whether thrombolysing would prevent them developing a chronic thromboembolic pulmonary hypertension. So there is no answer yet at present, whether with the intention of preventing the chronic thromboembolic hypertension. Otherwise, in submissive PE, so that the PESI score, that's what I was mentioning. And if there are the risk is high, if the troponin is high, right ventricular strain is high, then of course we may consider thrombectomy or interventional thrombectomy or thrombolysis in those patients.
Yeah.
If it's submissive.
And I remember that when I was a trainee in Australia 25 years before, there's a nice presentation by a thoracic surgeon actually those days, how they do the thrombectomy. You don't believe that? It's remarkable. Actually, hardly haven't seen in Sri Lanka. They do a lot of thrombectomy.
As we are behind the time schedule, let us conclude the symposium. I will invite my co-chair to hand over the certificates of appreciation. May I call upon Dr. Suresh Lakmuthu?
Next up, let me invite the Joint Secretary of the SLCP, Dr. Damit Rodrigo, to present the tokens of appreciation to the chairpersons. Thank you very much. Ladies and gentlemen, lunch will now be served.